Hello, everyone, and welcome to our American Head and Neck Society Virtual Education Series webinar on the management of low-grade salivary cancers. My name is Kieran Kakarala. I'm a head and neck surgeon at the University of Kansas and current chair of the AHNS Salivary Section. Our webinar today is a joint effort between the AHNS Salivary Section and the Multidisciplinary Salivary Gland Society. I'd like to take this opportunity to thank Vincent Vanderperten and the rest of the MSGS leadership team for partnering with us here at the AHNS on education and research efforts to advance the treatment of benign and malignant salivary conditions. This is actually the first of two planned joint webinars and hopefully the beginning of a more collaborative education efforts between our societies. The next webinar is planned for November 19th and will cover surgical techniques in parotidectomy to maximize form and function. Some of you may know that the AHNS Salivary Section Research Committee, under the leadership of Dr. Sajasevi, who's one of our panelists today, and Andrew Holcomb, has initiated an international research project to build a high-grade salivary cancer database. Over 100 sites around the world are participating in this effort, hopefully including some of your institutions. This is following on the heels of a very successful multi-center low-grade salivary cancer study, which that same group completed and which you'll hear about in today's webinar. So without any further ado, I'd like to thank our panelists and all of you attendees for participating in today's session and introduce our moderator, Dr. Ameya Asarkar. Dr. Asarkar is a head and neck surgeon at the Louisiana State University, and he's a co-chair of our AHNS Salivary Section Education Committee with Dr. Trevor Hackman. Dr. Asarkar, please take it away and he'll introduce our panelists.
Thank you so much, Kiran. Welcome everyone for our joint webinar on management of low-grade salivary gland cancer with the AHNS Salivary Section and the Multidisciplinary Salivary Gland Society. So today we have a great group of experts who will be discussing various aspects of the management of salivary gland cancer, low grade. From the American Head and Neck Society, we have Dr. Mirabel Sajasevi from University of Vermont Medical Center, Lerner College of Medicine. We have Ian Ganley, who is a head and neck surgeon at Memorial Sloan Kettering, New York. And from the Multidisciplinary Salivary Gland Society, we have Dr. David Lombardi from University of Brescia, Italy, and Boyd Gillespie from University of Tennessee Medical Center. So the objectives for our discussion today, as I mentioned, articulate the treatment extent of the standards for low-grade salivary gland section and appraise the current literature and develop an evidence-based algorithm for the management of these malignancies. Without further ado, I would like to start with the first case, but a couple of housekeeping announcements. If the audience, anyone from the audience have any questions, we'll be happy to take them. You could just type them in the chat box, and we can take them as we go between cases. So first case is a 57-year-old female with a parotid mass, left-sided parotid mass. On examination, she showed a 2 by 2 centimeter painless mobile left intra-auricular mass. She comes to the clinic with these CT scans and images, and what would be the next steps? I can start with Dr. Lombardi. So whenever you have a patient like this, how would you approach them? What is your practice?
Well, at least in our experience, a nodule like this would undergo, for sure, fine needle aspiration cytology, despite the fact that there is no worrisome complaint by the patient and the appearance of the lesion seems to be consistent with a benign lesion. But in a case like this, I would go for fine needle aspiration cytology.
Yeah, absolutely. So is this something that you do in the clinic with an ultrasound guided, or do we have the IR in your practice do this for you?
At least in our institution, fine needle aspiration cytology is performed by radiologists who take care about the ultrasonography and all, of course, CT and MR of the patients. So it's not performed on our own, but it's performed in a radiology department.
Okay, absolutely. I can go to Dr. Gillespie. So is your practice something similar, or you do any more office-based procedures as well for these?
Yeah, we approach it very similarly. Whenever you see a patient like this, the benign and malignant lesions in most cases present the same. You can do some skin prick testing and, just a good examination of the facial nerve and the regional lymph nodes, but generally you're just going to have a palpable mass. But we do prefer image-guided biopsies, typically with ultrasound for the more superficial lesions. And the main reason we send it away is just the availability of a quick pathological read, because these are probably the most difficult things to do in all of cytology. And to have a pathologist look at the specimen, or a cytotech look at the specimen, make sure it's adequate sample, that's very important. And unfortunately, we don't have that available in our office. So.
Okay. Dr. Ganley, what about in your practice? How do you proceed?
Yeah, we in our clinics we have a cytologist to do our fine needle aspirates. Cytologist is trained in ultrasound, so it's our pathologist doing the fine needle aspirate, but they've been trained in ultrasound. So the advantage of that is that, if it's a bad sample, we know straight away, and they can go back and get a more adequate sample. And also, they not only do fine needle aspirates, they do cell blocks. They're able to do that, and then they're also able to do further studies with immunohistochemistry studies and also fusion studies as well. So it's our cytologist in the clinic that basically is the key to the diagnosis of these lesions for us.
Yeah. So Dr. Sajisavi, is this your similar practice as well, or do you do your own ultrasounds in clinic?
Yeah, definitely. We have a couple ultrasound rooms, and it's basically an extension of my physical exam. So I would definitely take a look with the ultrasound. And one thing that we actually did in the last year was we have now developed a dedicated cytopathology clinic. So basically a day a month, we have the cytopathologists, pathologist myself, and we have just patients kind of lined up, thyroids, neck masses, carotids, and it's been really great because it just helps sort of streamline. Before we developed this, I would sort of do it without cytopathology, hope I got enough cells, or have to bring the patient back on another day. So that's been really helpful to, again, ensure adequacy and collect for additional material depending on what they see on the first pass.
Okay. So yeah, I think we also have a similar practice wherein the cytopathologist actually comes down to our clinic. We already have an ultrasound machine in the clinic. That also gives us an option, as you said, to evaluate the neck for any ultrasounds and so on. Yeah. So what are the guidelines for the FNA? Absolutely, FNA is recommended for any neck swellings, especially the salivary gland swellings, and open biopsies should be avoided as a rule. And I think it also gives us an opportunity to counsel the patients, whether it's benign or looking malignant. So the take-home point here would be an FNA for a thyroid nodule as you see them in the clinic. So again, this Milan classification was recently updated to the second edition. Maybe Dr. Lombardi, can you comment a little bit about Milan classification, and how do you integrate this in your practice?
Well, this classification has marked a very important point because it gives us a risk of stratification of the risk of malignancies of each major salivary gland nodule. And so according to the risk of malignancy, we can modulate not only the type of surgery, but also the time that we can expect before surgery, because at least in Italy we have some problem with the length of the wait for surgery. So we can modulate according to the results of cytology, either how much time can we put the patient in list for, and also we can modulate the type of surgery. And so it's part of our clinical practice every day, this kind of classification.
Absolutely. Thank you. So that's the biggest part about Milan classification, the risk of malignancy. And I think most of the guidelines now also mention that the path report of an FNA has to include the risk of malignancy with it as a standardized protocol. So this patient, coming back to our patient, the FNA showed a typical epithelial cell, suspicious for neoplasms. So what would be the next steps? Maybe Dr. Ganley, can you comment a little bit as to how would you proceed with this case now?
Well, firstly, two things that we would do. Firstly, to do full staging scans on the patient. If we're suspicious for a malignancy, then we want to make sure we've got a contrast CT scan of the neck. Sometimes we may do a CT of the chest. Sometimes we'll do a PET scan. If we're really suspicious that this is malignancy, we might do a PET as well. So that's number one, is just imaging to adequately stage. And then the second thing we do, which has become fairly routine for us now, is we do actually do fusion studies looking for fusion genes. A lot of cancers, of salivary gland cancers, have characteristic fusion genes. And that can give you an idea as to what you're dealing with, what type of pathology you're dealing with. And in addition, you can ask your cytology to do different staining, like staining for androgen receptors status, staining for HER2/neu, things like that. So basically, you want to try and get as much information as you can before you start your operation.
Okay.
So that's the way that we would handle it.
Yeah, no, absolutely. Thank you. That gives us a lot of information, the molecular testings as well. So, Dr. Sajisavi, like in your practice, do you refer to any molecular testing for these type of solitary salivary gland solely?
I must say that we don't, as just like kind of routine. I think maybe in cases of recurrence, or ultimately, let's say patients go to surgery and, depending on the final pathology, but then maybe we should. But I would say at this point, in this situation, I mean, this, kind of looks like a sump to me. I would, in terms of additional imaging, that patient came with the CT neck. So, I'm gonna do the ultrasound, also evaluate the neck myself. And if there was no worrisome lymphadenopathy, I think I would, at this point, have a discussion with the patient about sort of the classification they fell under, the risk of malignancy, and that definitive diagnosis and potentially treatment would be surgery. And that, unfortunately, that's sort of the limitation of the FNA.
Yeah. So I think that's what we proceeded to do with this patient. This patient did undergo surgery. And while discussing it, I tried to break it down as to different aspects of surgery. So we can start with the type of incision that one would use if we all agree that this patient would need surgery. Maybe I'll start with Dr. Gillespie with the type of incision you would use.
So, obviously with any salivary neoplasm, the key is to get the tumor out completely, negative margins, and preserve the function of the nerve if all possible. Since this is a relatively small lesion, odds are that it's probably benign, but not completely. I would do a standard approach, a modified Blair approach, gives good exposure to level 2 in the neck in case you do see some lymph nodes at the time of the dissection, gives you a broad approach to the facial nerve, and it would allow a sufficient, partial parotidectomy versus superficial parotidectomy.
Dr. Lombardi, would that typically be your plan when you're planning surgery for this patient?
Yes, I will add one more item, which may be a matter of discussion.
Okay.
I would, in a case like this, in whom we have about 30% risk of malignancy, I would take out the lymph nodes of the level 2 and send from frozen. And if they turn out to be negative, I will definitely go only for superficial parotidectomy. If they turn out to be positive, I would go for total parotidectomy and comprehensive neck dissection. This kind of technique, namely the sampling of the level 2 lymph nodes, it's in our opinion a simple way to stratify the risk of occult nodal involvement in the neck, and may modulate the treatment on the primary, because the removal of the deep lobe of the gland may be essential to treat either the primary tumor and the first basin of cold nodal involvement.
Yeah.
But of course, if there is no evidence of nodal disease, I would go only for superficial parotidectomy.
No, absolutely. With parotid level 2 being the first echelon of lymph nodes, it makes sense addressing it in some form. So Dr. Ganley, what do you think about the incision or the approach for the extent of surgery for this patient?
Yeah, I agree with both Boyd and David. I would do a modified Blair incision. And like David, I also do the same. I take out level 2 lymph nodes and send for a frozen section as well.
Okay. Okay. So just for the trainees on this call, the different types of incisions that we just spoke about, ranging from modified Blair in this picture A to a facelift modifications, and then to the U or the V. And as Dr. Gillespie mentioned, doing a modified Blair incision would give you the best exposure, especially to take those lymph nodes out if needed. So we talked about the incision and the exposure. Let's discuss a little bit about how the facial nerve is managed. Maybe Dr. Gillespie, what is your practice in terms of facial nerve monitoring, and how do you dissect around the facial nerve typically?
So we do routinely use facial nerve monitoring. As people like to say, the surgery is almost more of a nerve dissection surgery than a tumor dissection surgery. And because of that, the nerve monitor is very helpful. I do train residents. Having that there gives me some confidence as they dissect that they're not being too hard on the nerve and learning good technique. Certainly it's good to be able to stimulate branches as you need to, especially if you have a difficult dissection or the tumor. I had a case just a month or so ago where it looked like a superficial tumor, but it was actually below the nerve, and you're glad you have it in that case. So we do use it routinely, and the technique I typically use is just using the major identifiers of the nerve, the tragal pointer, the tympano stylomastoid suture line, the posterior belly of the digastric, to kind of triangulate the location of the nerve. So,
absolutely. Maybe Dr. Sajisevi, is that your similar practice regarding nerve monitoring as well?
Yeah, I'd like to echo those exact sentiments. I use it in every case, and had the same exact thing where there was a tumor that was unexpected. It seemed like it was going to be superficial. It was in the deep, and it was pushing the nerve very superficially. I didn't even realize I was staring right at it because it was splayed and so thinned out. But it kept stimulating, and sure enough, it was the main trunk, and I was like, wow, I'm glad we have this monitor. I think it's also very helpful to, if I will say, I don't sort of pragmatically just say I'm always going to find the main trunk and trace out all the branches. Sometimes if you have a small tumor, you may be able to sort of do more of a more limited partial parotidectomy, and maybe not necessarily find the nerve branches initially, but it's helpful to be able to stimulate the tissue that you're dissecting before you cut, until you ultimately find the branches. So definitely use it for every case.
No, absolutely. Like, it all depends on how the tumor is sitting on the facial nerve. Sometimes you have to do a combination of antegrade and retrograde dissection. I just wanted to quickly go over as to what do most people, or what do most surgeons prefer. And by and large, we did this this survey for the American Head and Neck Society salivary section a few years ago, and almost 77, close to 80% of all the members did use facial nerve monitoring. And this was a study that they published from Spain, and a similar respondents, over 90% of respondents using facial nerve monitoring. By and large, neither of these papers actually found any correlation between permanent inadvertent facial nerve injury and using of intraoperative facial nerve monitoring. And a similar study from Korea as well, more than 80% of respondents using facial nerve monitoring. I think the key home point is, yes, we do have the technology, but the knowledge of anatomy goes a long way along with it. I think all the panelists would agree with that.
Yes, it could be helpful for the younger who are assisting to our webinar that there is no clear-cut indication that makes use of facial monitoring mandatory in every single case. There are some cases in whom is strongly advised, like revision procedures, and the cases when the surgeon is going to perform extracapsular dissection. Otherwise, there is no clear-cut indication. I use it, the neuromonitor, in every single case because it may help also in modulating the dissection if there is a critical relationship between the tumor and the facial nerve. But if the question is it mandatory to use the facial monitor in every single case, the literature says clearly no. No. Apart from the cases of revision surgery and whenever you are going to perform an extracapsular dissection.
Yeah, absolutely. That's an important point. Moving on. Moving on to the next point regarding frozen section. Maybe Dr. Ganley, when do you employ frozen section in your cases of parotid malignancies?
Well, with regards to the neck, as David said earlier on, in cases of suspicious malignancy, I do a level 2 lymph node removal for frozen section. And just like David said, that then guides as to whether or not I need to do anything else to the neck. With regards to the primary, really the only indication for me for doing a frozen section is where the tumor is adherent to the nerve, or the nerve appears to be infiltrated, and you think that you have to remove a segment of the nerve in order to get clearance. So in that situation, I would want to get a frozen section to confirm that we're dealing with cancer.
Yeah. Dr. Lombardi, is that your similar practice regarding frozen section as well?
Yes, we have to be clear. There are indications for frozen section on the lymph nodes and indication for frozen section on the primary. But regardless, if you are looking to the neck or to the primary tumor, the answer you have to get from the pathology should be yes or no. You have not to ask to the pathologist the type of the lesion, if it's benign or malignant, or the grade of the lesion, subtype of the lesion. You have to ask, is it tumor or not? Is this lymph node metastatic or not? So the answer should be a dichotomic answer from the pathologist. So the question should be addressed properly. So I completely agree with Dr. Ganley. You have to ask if the tissue around the nerve is tumor or not, if the lymph node is metastatic or not. Apart from this clear-cut or straight indication, I don't think that frozen section may be helpful in other ways.
Yeah. No, I agree, and especially that goes with the technique of a frozen section, which we all know is just one section of the most suspicious area. So you may be missing some information from the other areas which are not evaluated during frozen section. But that's a very important point, Dr. Lombardi. So this is a study back a few years ago regarding a comparison between frozen section and FNA. And it did show that in certain cases, the positive likelihood of frozen section over an FNA is significantly high. So coming back to our case, this patient did undergo superficial prorectomy. We did use the preauricular, the modified Blair incision. We did use the intraoperative nerve monitoring, and all the facial nerve branches were preserved. And this was the final histopathology that came out. It was a low-grade tumor, no hybrid transformation of a myoepithelial carcinoma. I'll reach out to Dr. Gillespie, and how would you proceed now in terms of any adjuvant therapy, or would you just surveil the patient?
So that would be considered one of our low-grade histopathologies. There was a paper probably about 10 years ago that looked at predictors of mortality, and the tumor grade was almost one of the strongest risk factors for mortality. So this would be on the lower end, completely excised. I think this patient would be safe for observation. So.
Okay. Dr. Ganley, is this something that you would observe or recommend any further treatment?
Yeah, so it's a low-grade malignancy, and it's a low-stage tumor. So low grade and low stage means no indication for any adjuvant therapy. So no indication for any radiation.
Oh, perfect. Yeah, maybe I should have asked the audience poll before we had the experts chip in. But maybe JJ, can we still see how the sentiment is?
Yes. Launching the question now, you should see it.
Yeah, some would still will consider adjuvant, but I think it is a consensus that if it is a low grade with negative margins, it's safe to observe these patients. And this is essentially what we did as well. As of the last follow-up, the patient is locoregionally controlled. Quickly moving on to the second case, we'll change gears a little bit. It is a 36-year-old female who presented to your clinic with a history of resection of a preauricular mass, and the pathology, she came with the pathology result of low-grade adenoid cystic, which was present at margins, which is probably what happened was the surgeon outside had just done a biopsy or truncated it, thinking that it's a nodule. And this was her post-operative CT scan. This is how she presented to us. So I'll leave it for a second, and we can do another audience poll, JJ, to see what most of the folks think if they would approach.
Okay. Poll is open. Can you see that?
Yes.
Okay. Responses are rolling in. I will close the poll in 5 seconds. Okay, I'm closing the poll now.
Okay.
And here are the results.
Okay. I mean, fair bit around, but a majority would complete the surgery and adjuvant therapy. Okay, so let's ask the panels. So maybe Dr. Sajisevi, how would you approach? What would your next steps be? And a few considerations are these.
Yeah, I think further imaging is definitely a consideration. Both you could consider an MRI just with adenoid cystic carcinomas, propensity for perineural invasion would be good to get an understanding of that. And then also propensity for distant METs, so some chest imaging to get a baseline. Both of those things I would potentially consider, but agree with subsequently the audience of completion surgery and adjuvant radiation.
Okay. Dr. Ganley, is this a similar approach that you would take, or you would prefer a PET scan at this point?
So if it's adenoid cystic cancer, so you want good imaging of the primary, which you've already done. And yeah, you want to do either a CT scan of the chest or a PET scan, but probably CT scan of chest is fine.
So just to bring home a point, actually, we are doing, we are recommending, the panel is recommending a CT scan chest, mainly because these do have a propensity adenoid cystic for distant mets to the lungs. While saying that, this patient, we did get a CT scan chest and she did not have distant metastasis. If she did have distant metastasis, what does the panel think about treatment with curative intent or palliative or targeted therapy? Maybe I'll start with Dr. Lombardi.
First of all, I would stress an important point that whenever we have a biopsy performed elsewhere, especially in cases where we have a diagnosis which is demanding, like adenoid carcinoma, we ask for a division of the slides in every single case because we wanted to be sure that the diagnosis was correct. And of course, whenever we are dealing with adenoid carcinoma, we ask for MR and for chest CT because PET CT could be not so sensitive in identifying low metabolism pulmonary disease. So we prefer definitely CT of the chest and the abdomen rather than PET CT. In a case like this, whenever we are dealing with, sorry, I forgot the question.
No, in the face of distant metastasis in the lung, would you still curative intent?
As a general rule, whenever we are dealing with a low burden metastatic disease, this should not change the treatment on the primary tumor. We have to treat the primary tumor as it would be a M0 condition and then decide which is the best treatment option for the metastatic disease. So the discrimination here is between low burden on metastatic and high burden on metastatic disease. This make a single pulmonary metastasis should not change the treatment of the primary tumor.
Great point. Dr. Gillespie, would this your approach be as well in face of distant metastasis?
Yeah, I agree. I think treating the local regional disease first, given the fact that patients with adenoid cystic carcinoma, although long-term prognosis is very poor, it's still over 5, 10, 15 years in some cases. So they're going to have more morbidity from the local disease. I will say for this case, these are unfortunate situations, some gross tumor left behind, and surgery being the best, potentially best next choice. This is a case where I would go ahead and get my reconstructive surgeon involved. I'm fortunate to have very good facial plastic and reconstructive surgeons in my practice, and I'm going in anticipating that this lady's going to have a weak facial nerve, if not lose a branch of the facial nerve that could potentially be helped at the time of surgery. And she's likely to also need post-op radiation. So providing, if I do a total parotid, especially excising former scar lines, having some extra soft tissue coverage to the area can be very beneficial. So
that's a great point regarding reconstruction, absolutely. So this patient did undergo a parotidiectomy and en bloc resection of the scar. As you said, like the buccal branch was involved within the scar, actually. I remember this case. So we had to sacrifice it, but rest of the branches were preserved. And we were able to rotate a cervicofacial flap over it. Now, this was the final pathology, adenoid cystic carcinoma and low grade, which is expected, and the regional lymph nodes in level 2 were benign. What about adjuvant therapy at this point? Maybe Dr. Sajasivi, what are your thoughts on adjuvant therapy for this patient?
You pointed in the op note that, that it was considered low, but adenoid cystic carcinoma typically has a higher risk of recurrence. And so typically we would recommend adjuvant radiation therapy in most cases of adenoid cystic.
Yeah. Dr. Gamley, adjuvant therapy, do you agree with radiation as well?
Yes, in general, for adenoid cystic cancers, we will irradiate all of these cancers in general, mainly because of the biology of the cancer. It tends to be infiltrative carcinoma and exhibits perineural invasion. And therefore, we give adjuvant radiation to try and prevent local recurrence due to the presence of the perineural involvement. So that's reason number one for this case. But the second reason for this case is because the surgical field's already contaminated. And so in general, for cases where there's surgical field contamination from previous operations, we tend to advocate for post-op radiation as well, for that reason as well. That applies to not only for adenoid cystic, that applies to many cancers in general.
No, absolutely. And that's essentially what this patient was recommended, and also recommended in the NCCN guidelines, as we said, for adenoid cystic and in cases of tumor spillage or incomplete surgery in the past. Similar guidelines from ASCO as well, postoperative radiation for any resected adenoid cystic carcinoma. The patient is now locoregionally controlled for 9 months. I see some questions in the chat as well. So
We are related to the previous case.
oh, okay. Maybe we can come to that towards the end. Quickly moving on then to the third case, 51-year-old male with left submandibular region mass, which has been painless and progressively enlarging. The patient actually came to us with a report of a core biopsy, which did say neoplastic atypical cells, and then differentials, which actually included from epithelial neoplasms all the way to adenoid cystic carcinoma. And this was a CT scan with contrast for this patient. What would be the next steps? Dr. Gillespie, how would you proceed for these patients?
So, I mean, obviously that if that differential you gave was quite large, a lot of those are what we call basaloid neoplasms, basal cell neoplasms, and those can be very difficult to discern. This might be a case where some special staining of a core biopsy could give you molecular staining, could give you some more information. I don't think that's really going to change what you do. This ultimately needs to be removed. I think most surgeons, while they're in there, will remove the surrounding level 1B lymph nodes. But potentially, if you did molecular staining and knew it was a more aggressive subtype, you would do a more comprehensive suprahyoid, at least neck dissections.
Dr. Lombardi, what is your preference for this patient's extent of surgery?
Well, in a case, whenever I'm dealing with a submandibular gland lesion, I would not go simply for submandibular excision. I would at least remove the surrounding lymph nodes of the sublevel 1B at least, because it gives much more reliable evaluation of the margins around the tumor, because we do not have otherwise a good possibility of mapping the status of margin around the lesion. So at least I would go for sublevel 1B super selective neck dissection, let's call it in this way. In this case, probably, since we have a very wide variety of lesions in the differential diagnosis, I would agree, in order to restrict somehow the possibilities by performing some adjunctive assays or evaluation on the core biopsies that had been performed previously.
Okay, no, absolutely. So I think we talked about the surgical approach and the extent, and I agree the take-home point here would be level 1, addressing the level 1B lymph nodes along with the submandibular mass. And I think we also addressed a super selective neck dissection in the form of level 1B. And this is recommended in the European guidelines as well, at least a level 1B or the first echelon or level 2 in cases of parotid malignancies. So this patient did undergo submandibular gland excision, and actually the histologic report did show it to be a sclerosing microcystic adenocarcinoma, quite rare. So, Dr. Ganley, how would you approach it from here, this being a rare entity?
Well, I mean, the two things I want to know are, is the margin positive or negative? And secondly, is it low grade or high grade? So these are typically low grade lesions. So providing it's low grade and confirmed by the pathologist and the margin is negative, then you know, it's a stage T2, so be T2 N0 malignancy, low grade, negative margins. So I wouldn't do anything else.
Okay, yeah. So it did show a margin which was 1 millimeter from, although it was negative, but it was still 1 millimeter. So, and you touched upon this a little bit regarding the margin status. Well, I'll continue with you regarding your practice for margin cutoff before you consider adjuvant therapy for such patients.
Yeah, negative margins. Well, so this is for low stage tumors, so T1, T2, N0, and then grade. Okay, for high grade lesions, we tend to give radiation. For high stage tumors, stage 3, stage 4, we give radiation. For low stage tumors, so T1, T2, N0, no radiation, providing margins are negative. And for low grade lesions. So if this if this patient's got negative margins, then no indication for adjuvant therapy for low grade. And if it's close margins, also no indication for radiation, providing it's low grade. If it's got a positive margin, then we then have to discuss that at our DMT as to whether or not there would be an indication for radiation. And in that case, we're looking for other factors, other risk factors that might push us towards giving that patient radiation.
Yeah, absolutely. Dr. Sajisevi, your thoughts on adjuvant radiation therapy for these low-grade tumors?
I agree with how Ian outlined the reasons to give radiation and the reasons to withhold them. I think so. Just in terms of close margins being the sole risk factor in low grade and low stage tumors, agree that observation is safe. There's mounting evidence to support that practice, and patients have excellent local control with observation. However, if there are additional factors such as PNI or LVI, then we do consider it, or at least have our patients meet with radiation oncology to discuss the risks and benefits of adjuvant versus not.
So I think one thing we all agree is that if it's low grade and negative margins, these patients can be observed.
I have a question for Dr. Sajisevi, though, because I did reread her paper in preparation for this. And, you know, although there was no statistical differences, the radiated group with close margins, or the one had 0 recurrences, 0. The other group had, you know, a few. You know, that's not significant, but 0 is 0 at the end of the day. You know, do you even have a conversation with a patient about that, or do you just say the data is the data? We feel comfortable not offering that?
That's a great point, because if you're that, you know, 1 of 4 patients that do get a recurrence with observation, and obviously that's a huge deal. We do discuss with patients that typically with head and neck cancers, close margins is something that can be a risk factor for recurrence, but that again, there is data to suggest that for the majority of patients, with that being the sole risk factor, that's safe, and patients generally do well. And I would say most patients would elect to observe, you know, knowing that the risk is not 0. So you do have a good point. The other thing that's that I will also point out is this case is on submandibular gland cancers. And a lot of the data regarding the safety of close margins, most of the majority are parotid. So for example, in the multi-institutional study, with like 800 plus patients, at least only 7% of those had submandibular gland cancer. So sort of extrapolating a little bit, but that's what we got.
No, that's a great point. And for the attendees, this is the JAMA paper that Dr. Gillespie just mentioned, and clearly there was significant survival difference in patients with positive margins versus patients without negative margins when you compared who received radiation and who did not. And there was similar data with the MSK data from a few years ago, also showed similar findings during that subset analysis for low and intermediate grade tumors. So for our case, our tumor board did recommend observation due to this type of tumor being indolent nature, and there are literally case reports without any nodal involvement as well for this particular histology. And now the patient is locoregionally controlled. Quickly moving on to the fourth case. This is a 46-year-old male who presented to us with a left post-auricular mass, which was gradually progressing since the past 6 months. He basically had no other complaints, and we can see the clinical picture of that mass. He presented to us with this CT scan with the mass really close to the overlying skin, and the chest CT we got did not show any distant metastasis. So what would the next step be? So Dr. Lombardi, how would you proceed?
I would definitely go for MR before planning any kind of surgery, because there are some the clinical presentation of the lesion is not so indolent. There is a possible critical relationship with the skin, and the lesion has a quite high growth rhythm because it appeared in 6 months and reached a remarkable dimensions. So in this case, before performing, I would go for a fine needle aspiration and for MR in order to have all the elements necessary to plan.
So for a mass this size, when do we consider a core biopsy versus a fine needle? Or fine needle would be still our first choice. Maybe Dr. Ganley?
Usually fine needle aspirate is what we do. Rarely will we do a core biopsy unless the tumor is necrotic and we want to try and get a larger piece of tissue which has some viable tissue present. Yeah, because we can usually get most of our information from the fine needle aspirate, though. Even with molecular studies and fusion studies, usually fine needle aspirate is sufficient.
Yeah, this patient did undergo fine needle aspiration.
I will say, Amaya, in this case, I told you at the beginning, just the way my clinic's set up, I have to send patients out for FNA, but I can do core in my clinic and then you're getting a good sample. Sure. This is based on this guy's skin involvement, you're going to end up resecting most of that skin, so you're not really worried about tumor seeding as such. I mean, I think this, if your clinic is like mine, this is a case where I would do a core, send a nice specimen to the pathologist, and save the patient a trip back to the radiology suite. So,
but that's an excellent point. Actually, it never occurred to me, but that's an excellent point there. Thank you. So we ended up doing an FNA. It did show us suspicious for malignancy. So how do we proceed? Dr. Sajisevi?
So I agree with sort of the comment earlier that this, it seems like it is a bad actor, and the CT scan, I feel like I'm not getting a really great sense of where the tumor is and the tumor isn't. So I definitely would get some more imaging, including MRI for the primary, but I would consider a PET CT too. Even though the FNA was a sort of not fully diagnosis, just the whole picture looks like malignancy. And based on obviously the further imaging, that'll certainly help guide the extent of surgery, which again, just looking at the CT, I would have a long discussion with the patient about the possible things that might need to be done in the operating room, including facial nerve sacrifice, reconstruction, have the relevant colleagues available, otology, et cetera. Again, we don't have enough information yet, but just based on the CT and his presentation, it's kind of looking like it's heading in that direction.
Yeah, no, absolutely. Like, it's definitely not behaving like a low-grade tumor, if you may. So we did decide that for this patient, the best would be surgery, excise the skin overlying the mass. And this is how it looked intraoperatively, going from left to right. You see this mass over the skin, and the facial nerve identified as the distal branches, but the mass was literally adherent to the main trunk of it. So we can get the audience involved in this poll, maybe JJ, to see what they think about the next steps.
Okay, question is launched.
Mhm.
And responses are coming in. I'm going to give it about 20 seconds. Okay, I'm going to close the poll in 5 seconds. Closing the poll now. And here are the results.
Okay, so pretty like distributed evenly, almost close to evenly across all the options that we presented. Let's start with Dr. Ganley. What do you think? How would you proceed in an intraoperative picture like this?
Well, the clinical presentation of the patient is of a malignancy and of a high-grade malignancy. This is not a low-grade lesion clinically by the history. By the clinical exam, it also looks like a high-grade lesion with the rapid growth and the skin involvement, even though the facial nerve is intact. And then thirdly, the imaging is not well defined. It's a poorly defined primary tumor. And so that's also an indication that you're dealing with a high-grade malignancy. So in these situations where I know when I'm going into the operating room, I'm going to be dealing with a high-grade cancer, it's very important that you prepare for these cases before you get into the operating room. And so for these cases, I ask following questions. Number one is, what is the extent of my resection? What am I anticipating to remove? Number two, what is the resultant defect that I'm going to create? And do I need a plastic surgeon to resurface, to recontour the face? Number two. Number three, what do I think is the chances that the facial nerve's going to be involved here? And do I need a plastic surgeon to do facial reanimation for me? The fourth thing I actually ask is, what's the chances that I'm going to need radiation for this? Okay, so I have to ask all of these questions before I get into the operating room. And so in this particular case, I know that this is going to be an extensive resection, number one. I know I'm going to need a free flap to recontour the face. We routinely use ALT free flaps to recontour our parotid defects nowadays. Because the plastic surgeon is going to be there to recontour, I routinely use our plastic surgeon who specializes in facial reanimation. So I get him involved with all of these cases. And so he does all these cases with me. And so I prepare the patient for a possible facial nerve sacrifice, so the patient knows before we get into the operating room that has a strong chance that could happen, and so the patients are prepared.
Yeah.
And then lastly, I know this patient's going to need radiation, so that's the other benefit of having a soft tissue reconstruction in these cases, is that when the patient goes through radiation afterwards, they will maintain a good symmetry to their face. Whereas if you resect and take out a large defect and do not provide soft tissue cover, the patients will look terrible afterwards once they get radiation, because that sunken look gets emphasized with the radiation, with the tissues getting sunken in. So basically, my advice to anyone in these types of cases is be prepared and have a plastic surgeon available to do your soft tissue reconstruction and available to do your facial nerve reanimation all at the same time.
Absolutely. There are different considerations, a lot of considerations that go into when operating on such cases. Maybe Dr. Lombardi, can you tell us, like, would you do anything different for the facial nerve? Would you sacrifice it, send frozens, and so on and so forth?
Well, provided that the function of the facial nerve was normal before surgery, we are not allowed to sacrifice without any histologic confirm that the nerve is infiltrated. So whenever we are dealing with a situation like this, when we have a functional nerve preoperatively and we have the suspect intraoperatively of infiltration of the nerve, we have to send for frozen the tissue around the nerve, and we have to decide whether, according to the results of the frozen section, if we have to sacrifice or not the nerve. In a case like this, I would add also the management of the earlobe and of the mastoid and or the temporal bone to the planning, because according to the preoperative pictures, the lesion could have, I don't know, but could have a critical relationship with the underlying bone and with the underlying cartilage of the earlobe. So we have to include also these two structures as a possible site of resection when we have to plan the surgery in a case like this.
Yeah, no, absolutely. So as far as this particular patient goes, we did proceed with the surgery. We were able to get the tumor off the facial nerve. It was intact, so we did not sacrifice it. It wasn't involving the temporal bone, so we did not have to extend our surgery. We completed the neck dissection, although the final pathology did show that it was low grade and the deep margin was positive. The deep margin was basically shaved off the facial nerve. So what would be the next steps? Any role of any targeted therapy, Dr. Sajisevi, or just you would recommend radiation?
I must say at this point, we haven't used targeted therapies first line in mucoepidermoid carcinoma. Certainly for high-grade salivary ductal, we'll do like HER2 and things like that. But I'm curious to see what the other panelists are doing for this. But definitely, as you mentioned, even though it says it's low grade, it's certainly not behaving as such. So we would certainly recommend adjuvant therapy, radiation.
Dr. Gillespie, any thoughts of any targeted therapy for patients like these?
Yeah, no, I don't think so. Low-grade tumor, not really a subtype that tends to respond. We still, in cases of, high-stage tumors or, aggressive subtypes, we tend to still use more platinum-based chemotherapy because I don't think any of these targeted therapy has shown to be superior to that. So.
Yeah, I agree. For low-grade tumors, I don't think we have enough evidence for any of these targeted therapies. So this patient just received radiation and he was doing well at the last follow-up. JJ, do we have do we have time for one last case? Or
Amaya?
Yeah, I'm okay if we want to.
Amaya, I might suggest there were a few questions in the
Okay.
chat. You might want to address at least one or two of those instead of this last case.
Yeah.
One question that kind of came up a couple times is the terminology we're using around parotidectomy, superficial versus total versus partial versus extracapsular dissection. In the setting of low-grade malignancy, it might be nice to hear from the panel how they think about those terms and do those procedures in their own practice.
Well, whenever you remove the complete portion of the parotid superficial to the facial nerve, it's a classic epidural or superficial parotidectomy. It becomes total if you remove the tissue below or deep to the facial nerve. And according to a recent classification, you may also divide the superficial and deep lobe in two quadrants, and superficial is quadrants 1 and 2, and deep lobe is quadrants 3 and 4. Extracapsular dissection is a technique that implies that you do not go for the main trunk of the facial nerve, and you go for your aim is to remove the tumor with a cuff of healthy tissue around, and you do not go for identification for the facial nerve and use the pneumomonitor to identify and preserve the branches of the facial nerve around the lesion. So it's a completely different technique, because in a classic epidural or total parotidectomy, you go for the facial nerve main trunk, and then you follow the peripheral branches in order to preserve the nerve. When you are performing a extracapsular dissection, you do not go for the main trunk, and you remain around the lesion with a cuff of healthy tissue, and you identify only the small branches around the lesion.
Yeah. Do we have another question? Okay. So, Karan, do you want to add any more questions, or are we good? So to sum it up, we had some great points by all our panelists. But if we have to take home some points, then the workup of salivary gland cancer should always follow evidence-based paradigms. There are new and emerging entities in terms of the histology of salivary gland pathology, and it's important to know these so that the treatment can be tailored on a case-by-case basis. Safe handling of the facial nerve is crucial. That goes without saying. And adjunct therapy for high-risk features only after a multidisciplinary discussion, because some of the low-grade tumors with negative margins can still be observed. I would like to thank all the panelists for taking time out from their busy schedules. It was a very engaging discussion. Thank you so much.
Thank you, everyone.
Thank you.
And please look out for an email from the Head and Neck Society. Our next joint panel will be in November, again on techniques in parotidectomy. So look forward to seeing you then. Thank you.
Thanks, everybody.
Hi,
Thanks,
hi,
everyone.
hi, everybody. Thank you so much.